Hello and welcome everyone to the September 28th Virginia Opioid Abatement Authority's Abatement Academy. My name is Jennifer Nelson, Virginia Institute of Government, Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work toward our vision of good governance, equity, and resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training programs. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a team of seasoned public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, leadership team strategic planning retreats, and other related events. Today, VIG is glad to partner with the Virginia Opioid Abatement Authority for the Abatement Academy Series, number 13, presented every second and fourth Thursday through 2023. Here are a few housekeeping notes. This session will be recorded and posted on the Weldon Cooper Center for Public Service YouTube channel soon. If you have any questions, please type them in the chat and I will ask them for you. Thanks again for taking the time to join us today for this Abatement Academy session. And now I'm happy to turn things over to Adam Rosatelli, the Authority's Finance Director.
Well, thank you, Jennifer. I appreciate it. And hello, and again, welcome to today's Abatement Academy webinar. Again, my name is Adam Rosatelli, and I'm the Director of Finance for the Opioid Abatement Authority. And as Jennifer mentioned, this is now the 13th installment of a series of free bi-weekly webinars launched by the Virginia Opioid Abatement Authority and the Virginia Institute of Government for the purpose of highlighting examples of programs that align with nationally recognized principles for the use of funds from opioid litigation. So for this Abatement Academy webinar, which is the first in the series, excuse me, of focusing on Principle 4, which is a focus on racial equity, we are very fortunate to have with us today Kristen Pendergrass to discuss the topic of resources and methods to overcome barriers to access. So Kristen serves as the Vice President of State Policy at Shatterproof, which is a national nonprofit organization dedicated to ending the course of addiction, the addiction crisis in the United States. So previously, Kristen worked at the Pew Charitable Trust leading state relations and strategy for the Substance Use Prevention and Treatment Initiative, and for the Pew MacArthur Results First Initiative, helping state and local governments incorporate evidence-based policymaking into the budget and policy processes. Before joining Pew in November of 2015, Kristen worked as a policy advisor for the House Majority Caucus in the Oregon Legislature, Chief of Staff to the Oregon House Majority Whip, and as legislative assistant in the Massachusetts House of Representatives. Kristen holds a master's degree in social welfare policy from the Boston University School of Social Work and a bachelor's degree from Vanderbilt University. So pretty impressive stuff. And with that, Kristen, I'd invite you to begin your presentation.
Thanks, everyone. And thanks so much for having me. I'm really excited to kick this principle off for everyone. Just as a brief agenda overview, I'm going to give a quick overview of who Shatterproof is and the kind of work that we do, and then talk about equity, both in the process of the opioid settlement funds, and then also getting down to the actual continuum of care and addressing substance use disorder in an equitable manner. And then towards the end, we'll talk a little bit more about stigma, which is the theme that will run through everything we talk about, and then some resources. If anyone wants to dig a little deeper, learn more. So Shatterproof, as Adam said, is a national nonprofit dedicated to ending the addiction crisis in America. We were founded about 10 years ago after our founder, Gary Mendel, lost his son as a result of his addiction. So Gary created Shatterproof to provide the kind of resources and services and education that his family would have really benefited from as they were dealing with Brian's addiction. So 3 main pillars of our work: increasing access to quality treatment, quality being the operative word. We have a quality addiction locator called Treatment Atlas. It's treatmentatlas.org. It's available in 14 states. Unfortunately, Virginia is not yet one of them, but really trying to help people understand quality treatment and be an objective resource for accessing that. Second pillar of our work is ending addiction stigma. Like I said, we'll talk more about that towards the end of my presentation, but a really important part of of making sure that people have access to the care that they need. And then finally, educating and empowering communities. So we've got a lot of resources on our website, just educational about the kind of the state of substance use disorder in America, and then what people can do. We also have our policy arm, which is what I'm a part of, and these are our 4 advocacy priorities. You'll see that opioid settlement funds is one of our main priorities, and this is mostly focused on the good governance side. So supporting the principles, making sure that states, mostly, I'm one person, 50 states is a lot. So we don't do a lot with local governments, but we do support the work of other organizations at the local level. But making sure that the funds are held separately, that they are dedicated towards addressing substance use disorder in America and abating the opioid crisis, and that everything is transparent, that there's reporting, et cetera. Our other advocacy priorities are about bringing substance use disorder care into the primary care setting, making sure that healthcare providers are trained and educated around substance use disorder, and then finally addressing the unique challenges that fentanyl brings, given how omnipresent it is and how potent it is in the illicit drug supply. So focusing on opioid settlement funds. As you all know by now, I hope, Johns Hopkins led the creation of a set of 5 principles to guide local and state governments administration and spending of the settlement funds that are currently coming and will be coming for the next, I think now it's 17 years. They also led the endorsement of the principles by now over 60 different national organizations, and Shatterproof was one of the early co-signers or endorsers of the principles. And one of our main roles in this space is bringing all the organizations that have endorsed the principles together. So we lead a monthly working group meeting of organizations that are creating resources and that are tracking what's happening. It's a place where we share challenges that we see, where we also try and highlight or states and local governments that are doing an exceptional job at addressing this issue and applying the principles. If you would like to nominate your local jurisdiction, there is a nomination form at the principal's website, which there's a link to at the very end. We really do want to highlight the good work that's happening around the country. A lot of what we hear is, how are people addressing this? And then we're able to point them to someone who has done that well, or who is also grappling with it and make those connections. So rest assured, I'm not going to go through all 5 principles. I'm sure you all have heard these a lot, but just wanted to remind everyone that these are the 5 principles that those 60 plus organizations have signed on to, and that I think it's over 20 state governments have referenced either in their laws or their MOUs or just in the, like Virginia is doing in the way that they're approaching the decision-making and spending. As you know, today we're going to focus on number 4, the racial equity piece. I'm going to talk a little bit more broadly about equity than just racial equity, but racial equity will be kind of the cornerstone. And I am going to touch quite a bit on number 5, developing a fair and transparent process, but it's more about how we bring equity into that. So as a reminder, here is principle 4 and kind of the subcomponents of it, investing in communities that have been disproportionately impacted, supporting diversion from arrest and incarceration. We know that the way that substance use disorder and drug use in general in the United States in the past has been approached from a very punitive point of view. So addressing that part of the landscape, funding anti-stigma campaigns, and then involving a diverse set of community members. So this is the general slide that we usually use to talk about equity and how jurisdictions can address equity in their process. So it's looking at the makeup of your advisory boards and councils, including people with lived experience, and then the harm reduction experts, also thinking about the role that different positions play or different people play, whether they're allowed to vote on recommendations, et cetera. The next, of course, is a criminal justice setting, thinking about supporting people with a substance use disorder instead of punishing people with a substance use disorder. I usually talk about it in terms of bringing a public health approach to this issue as opposed to a criminal justice approach. Looking at diversion, deflection, treatment courts, kind of that pre-involvement space, getting evidence-based treatment or medications for opioid use disorder into the criminal legal system. Medications are universally known as the kind of the gold standard of treatment for opioid use disorder, and then also looking at reentry services. And I'm going to dive deeper into this in a little bit. And then finally, looking at Exhibit A, I think it might be called something different in Virginia. It's called something different in most places, but thinking about approved uses, that list of core strategies and approved uses, looking at stigma reduction, peer support, and then community providers and wraparound services. So as I mentioned, I'm going to talk a little bit more about building equity into the fair and transparent process and how to think about this. Wanted to just level set. This is, I'm sure there's a million definitions of equity. This is one that I liked that I got from NACO, or the National Association of Counties. So just keeping this in mind as we go through this presentation, thinking about identifying, this is going to be another theme, and then removing barriers that end up at creating disparities in accessing resources. So this is another concept that I wanted to introduce because it really resonated with me when I first heard it a couple years ago. And I think it's really important when we think about building equity into a process. So it's this idea of building it into the process instead of bolting it on after the fact. I heard this first from a disability rights advocate named Kathy Martinez, but you can see on the left that the ramps were built into the design, and on the right, this was bolted on after the fact. And in addition to being quite ugly, I have questions about how useful it is. We also know that when things are built into a system to accommodate other people, whether that's because of a disability or whatever else, they also have kind of secondary effects. Like a mom with a stroller, it's probably much easier to use the one on the left than the one on the right. And then this is another way to think about built in versus bolted on. When you think about all the different possibilities, as you move down the process of kind of refining your design alternatives or the alternative ways of approaching something, the cost to change your mind goes way up. So if you just build the ideas of equity, accessibility, et cetera, in from the beginning, then at the end, they won't cost so much, right? It won't be as much effort to put them in after the fact, or bolt them on after the fact. So instead, building them in from the beginning, from the original design. Okay, so this is the general fair and transparent processes. I talk about it, these 5 components: and needs assessment, diverse input, strategic prioritization, which is really just funding, transparent reporting, and tracking outcomes. I'm going to talk about the 4 on the left because I think tracking outcomes is very similar to the data that's really the main component for me of the needs assessment. So thinking about data, advisory councils, funding, and then reporting. So this is the current, the most current data that I could find on the overdose rate, death rates by race and ethnicity in Virginia. So this is Virginia specific. It's not the easiest thing to read. The top line is for all people in Virginia. The next line down is for white people in Virginia. The next line down is Black people. The one that's just barely visible above is Hispanic. And then those 2 at the bottom are all the other categories. It's important for us to know who's being impacted. And not only, this is actually, I misspoke, this is not rates, this is raw numbers. But I think rates are important as well. What proportion of any given population is impacted, and how is that changing over time? We know that the opioid crisis as a whole was originally impacting white communities much more than it is now. Currently, the highest rates of overdose are among people of color, specifically Black and Native American populations. So thinking about we have to know what's actually happening out there before we can address any inequities, because we don't know what inequities exist, right? So that data component is really important for kind of setting the stage, creating giving us a better understanding of what's actually happening in our communities. And another, I don't have an image for this, but just a story I'll tell. When I worked at the Pew Charitable Trust, we really focused on increasing access to medications for opioid use disorder, and we were doing work on methadone. And the common understanding of methadone is that it is much more likely to be offered to Black people with opioid use disorder or people of color with opioid use disorder than it is to white people. The kind of general idea is that white people get offered buprenorphine and people of color get offered methadone. We were working in a state that is very near to Virginia, but not Virginia. And they had the data because we talked to them about, we were working with them on methadone and their regulations around opioid treatment providers or methadone clinics. And we brought up this equity issue, and they actually had the data, and they said, no, in our state, it's actually much more white people that are on methadone. And so having that data is just so important to guide your process and your decision making, and knowing whether or not there's an equity there to begin with. So I'll keep bringing this up, but this is the general idea that data helps us understand exactly what's happening, and disaggregating the data by race, as well as by other things, if you can, is incredibly important for informing the approach. Okay, advisory councils. This is, I know that the state's advisory council is set right now. We are hearing of some jurisdictions that are making kind of tweaks. But a big thing that I'll say is that there's a way to do it on paper and there's a way to do it in practice. So this is some work that Shatterproof did along with Johns Hopkins and KFF Health News, I think is their new name, about who's actually on advisory councils around the country at the state level, and kind of what category do they fall into. So this is the general, this is one of two visualizations of who is on the council in terms of their profession or their kind of the seat that they have, whether it's an elected official or someone who represents a medical and social service provider, et cetera. And I'll show you Virginia in a second. This is another visualization of kind of the scope of their power, how much of the funds they oversee, and the seats filled. So this is what Virginia's looks like. We did this, I think we finalized it in June. So it may have changed by now. And I'm going to reiterate the point I made before about there's a way to do it on paper and there's a way to do it in practice. Obviously, people are complicated humans. And so someone who is in law enforcement could also have lived experience. One of, I think, the drawbacks of this whole reporting endeavor was that it's really hard to know what people are representing and who they are as people. So that lived or shared experience was really when it's spelled out in law that someone had to have a lived experience to fill that seat. That's not to say that someone who's a government representative or an elected official doesn't have lived or living experience. That's why I say there's a way to do it on paper where you could reserve a certain number of seats for people with lived experience. And then there's a way to do it in practice, right? Similarly with racial equality, we obviously did not go through and decide what race everyone was on every seat in on every council in the United States. But thinking about racial equity, again, there's a way to do it on paper, which we saw in a couple of states where they specifically called out that this person needed to represent a racial minority group or a community organization that works with people of color or something like that. But then there's a way to do it in practice by who is the individuals that are actually being appointed. Make sure I'm not missing anything. Oh, and then the other point around this is the voting versus non-voting, the power that the individual seats have. You can put someone on who has lived experience, but not give them any power to actually make their voice heard. So thinking about that. And then one other thing I'll say, and just in the way that I've seen different experiences and diversity incorporated into advisory councils and the actual meetings is by giving open comment period. I sit in on a lot of Nevada's meetings just to kind of watch how they run. And they always have an open, public comment so that people, whoever they are have the ability to come and make their voice heard. And I guess one other thing that I'll say is making these accessible to people. So this is wonderful that, this is online and available. I saw the closed captioning come up, but making sure that meetings of this kind are available to people with different abilities and from different spaces, including very rural places. All right, and then this is just another visualization of ways to think about diverse input. Like I said, we're talking about racial and ethnic diversity for the most part today, but also people with lived experience, thinking about professional diversity, and then also that geographic diversity. And then there is a resource that came out very recently from NACO and Johns Hopkins. They're calling them quick guides, and it's mostly things to think about. I was asked the other day about what does a perfect advisory council look like? And there's no answer to that. People are complicated. They have multiple identities. So I don't think there's any perfect makeup, but just this quick guide is a great kind of starting place to think about the diversity and input and the different aspects of that. So next, I want to talk a little bit about funding. Normally, when we talk about this, we talk about the funds are coming in for 18 years. There's all these different funding streams, making sure that we are prioritizing, using Medicaid funds first, but also thinking about being strategic about what the settlement funds should be used for. When thinking about addressing equity through this, obviously there's where the funding is going, but I wanted to highlight this example that I just heard about last week that happened in Colorado. The Colorado legislature appropriated $150,000 to a nonprofit called the Colorado Consortium for Prescription Drug Abuse. No, that's not right. It's something like that. The Colorado Consortium is what we call it. And it's housed at the University of Colorado. So they gave the consortium $150,000 a year to hire grant writers and grant managers. And this was mostly focused at for as a service for community organizations that serve low income and people of color. And they ended up seeing a $47 to 1 return on investment. So for every $1 that was put into this program, the $150,000, they saw millions of dollars coming into these local organizations who never would have been able, just because of capacity, right? They're small organizations serving smaller populations or more rural populations. They were just able to maximize the funding that they were able to get. I don't know if any of you have ever applied for a federal grant. It takes a lot. They're long. There's a lot of data required. The reporting is insane. Like it takes a lot of time and effort, and a lot of these small organizations don't have that kind of capacity. So I thought this was a really innovative way to get more funding into those community-based organizations. And then this is a new resource that just came out. It's from my former employer, the Pew Charitable Trust Substance Use Prevention and Treatment Initiative. These are 10 principles for financing substance use care and treatment, treatment, and support services. We just called them the financing principles, but it's ways to maximize funding. And they have I just read through it a couple of days ago. They have a lot of great ideas for addressing equity through funding, including data, but also different ways to think about focusing where funding is going. And then finally, transparent reporting, thinking about what you're reporting out in terms of where the funds are going, and then also how it's reported in terms of is it just posted on a website, or is there some outreach, some effort to make it available to people? And then I'll mention again, accessibility, the accessibility of what's being reported. So this is usually one of the better states that we highlight is North Carolina. I think it was about a month ago that they put this out. They have mapping for all of the different projects and proposals that have been funded around their state. Most of their funding is going to local communities. So you can see this map here. Exhibit A, I think for North Carolina, translates to Exhibit E for the rest of the country, but the high impact strategies or the core strategies. So these are the 21 local governments that have reported spending in this area or on those strategies. And then they break it down by exactly what they're spending it on. So you can think about, from that earlier slide, looking at things like criminal justice diversion programs and different interventions that are more likely to address equity lens or racial equity lens. And one other thing I want to say about reporting, I think there's often it's seen as an accountability thing, like reporting out so that other people can get mad at you. And that is not the way I look at it. Like, I get to travel the country and see how all these different states and local communities are addressing this issue. And first of all, every community is different in the challenges that they're facing and what's best for them, like where their settlement funds are most needed. So I see this really as a way to highlight and show off all the good work that's happening. So I just if you are an administrator of the funds and you're thinking about reporting, try not to think about it as like a gotcha. Someone's going to put this in the media and get mad at me. It's also a way to highlight all the good things that are happening, and all of the really innovative services that are being funded. I talk a lot about evidence-based services, and people often think like, oh, I can't do a pilot program. Yes, this is what this money is for. It's such a great opportunity to be creative, but we need to be showing each other around the country how we're spending the funds, and the innovation that's coming out of this. All right, so now we're going to get into the continuum of care, which is not really the right way to call what I'm going to talk about, but the 4 buckets doesn't look as good on a screen. So these are usually the 4 buckets that people talk about when they're talking about substance use disorder. So primary prevention, harm reduction, treatment, and then recovery. So this is from SAMHSA and HHS, the way they approach it. There's a lot of different visualizations of this. This is another one, prevention, treatment, recovery. And then let's do one more. Prevention can be broken out into primary prevention, secondary prevention, and tertiary prevention. So most of the time when we're talking about prevention, we're talking about that primary prevention, mostly for young people, stopping drug use or substance use disorder before it starts. Secondary prevention is early intervention. So stuff like universal screening, early detection, making sure that we're catching it early before it becomes a major health problem. And then tertiary prevention is also known as harm reduction, which is once someone has a substance use disorder, just reducing the overall harms that are associated with that. So when we think about, I'm going to go back to primary prevention. When we think about primary prevention and how to address equity within primary prevention, the image up on the screen is just a screenshot of a clearinghouse of primary prevention programs. It's called the Blueprints for Healthy Youth Development Clearinghouse, and it's run out of Colorado as well. It is a very large compendium of all of the different primary prevention services and programs that have been evaluated to see if they're effective or not. And I went into it, and you can see on this drop-down menu on the left that you can filter all of the different programs in there by the target population. So if you are in your community, if you are wanting to start or implement a primary prevention program that really looks at the Asian community, you can filter it by that, and this clearinghouse will show you programs that have been proven to be effective for reducing harmful outcomes or being effective at whatever outcomes they're looking at in preventing those outcomes for the Asian community. What else was I going to say about this? Yeah, you can see on the left, and again, we're focusing on racial equity today. You can see the different categories that they have. You could also think about age. Do you want to target the youngest kiddos or maybe teenagers? Do you want to look at different gender identities, etc.? And then the other thing that I wanted to mention, again, when we're talking about evidence-based programming, I talked a little bit about pilot programs. It's really important to have pilot programs. Maybe you can't find a prevention program that targets the community that you think really needs this program wherever you live. That's fine. Create a pilot, but then also include some kind of evaluation on top of it so that we can know if it works, right? If it's not producing the outcomes that we want, then we know and we can tweak it. And that just helps us be better stewards of the resources that we have. And then one more thing about this evidence-based, there's often a tension between evidence-based programs and culturally relevant programs. I think that it's a Venn diagram and that there are programs in the middle that are both culturally appropriate and evidence-based. But obviously it's most of the evaluations that are out there are not evaluating the impacts on a particular community. And that can be really frustrating. If you want a program that is a prevention program for African-American youth, it might be, there's less programs out there that have been proven to be effective for that community. So I just want to acknowledge that. And I've been in evidence-based policy for a long time, and it's an ongoing conversation that I think there have been efforts to improve it, but just takes time. All right, and then harm reduction. On the right, you'll see, I think this is often a very political term, and I want to kind of tone it down a little bit, take the politics out of it. Harm reduction is both an approach, but it could also be a program. And it's just the idea of keeping people healthy, giving people the tools and resources they need to keep themselves safe and healthy as possible. So I think that there's a way that we need to maybe change or temper our communication around harm reduction. Also thinking about the different services that are offered. Harm reduction services can be anything from naloxone to HIV testing. You can see here in sunscreen could be a harm reduction intervention. There's a lot of different services that can be offered. And again, tailoring that to a specific community and what their needs are. And I think one of the main tenets of harm reduction, which I think is getting a little overplayed right now because it's being used everywhere, but is meeting people where they're at and asking people what they need. Sometimes, you know, there's always in homeless services, it's socks are the #1 requested item, right? So it wouldn't have been the first thing I would have thought of, but someone asked, you know, people who don't have homes, what services do you need or what products do you need? So thinking about the different services that are offered and really asking people what they need and what they want. Thinking about different settings. I don't know if you guys do. I have this picture in my head of harm reduction being offered in an inner city or an urban area, but harm reduction services are needed everywhere. So thinking about not only unique settings, but also thinking about that geographic diversity and making sure that the people who live in rural areas have access to the services or products as well. And then unique partnerships. I've heard of some really interesting partnerships between law enforcement and harm reduction. I visited a harm reduction organization in Colorado where they were offering training to local law enforcement about how to avoid accidental needle sticks. And I thought that was a really interesting partnership. I've also heard of partnerships between harm reduction organizations and faith communities. So bringing those two groups together, which may not always be the first thing that people think of. Next, treatment. This is probably what I know best and probably what I'll talk about the most, but thinking about medication access, I talked before about the vision out there that buprenorphine is offered to white people and methadone is often offered to people of color. Like I said, that's not always necessarily true, which is why data is so important. But knowing that there can be barriers to different communities to each of those medications. And it's really, in my opinion, should be a clinical decision about what someone and their doctor, what works best for someone and what their doctor, you know, thinks is going to work best for them. So making sure that people have access to ideally all 3 forms of medication. I didn't include naltrexone on here just because it's not as popular and we don't talk about the barriers as much, although cost is a major barrier to naltrexone. And so just thinking through, like, what are the barriers to buprenorphine access? We know there are a lot of barriers to methadone access, which I'm happy to talk more about, but yeah. And then thinking about settings. So bringing substance use disorder care into the primary care setting. At Shatterproof, we advocate for a model called the collaborative care model, which brings behavioral health treatment into the primary care office through a 3-person care team, universal screening, et cetera. But there's a lot of other models out there. So how can we normalize substance use disorder treatment and also take away the stigma of it? Sometimes we hear that primary care doctors don't want those people in their offices, but they're already in their offices. They're just not screening for it. So I think primary care is a great place to address access and also to address stigma. Specialty care, of course, is important. I mentioned Treatment Atlas, which we have that helps people find specialty care. There are a number of other resources out there. SAMHSA has a care locator, but looking at barriers to that, you know, whether it's inpatient, residential, et cetera. Obviously, cost is a major barrier, insurance coverage, et cetera, but there are other barriers, including geography and things like that. Kind of a newer space that's coming out is mobile access. So this is especially, I think, well, one of the more interesting ways that I've seen it applied is in rural areas and frontier communities. So having a mobile van that's able to go out to meet people where they're at, and offer care, whether that's buprenorphine, whether it's wound care, whether it's methadone. There's a lot of new mobile access points that are coming up. So for methadone in particular, there are mobile vans, and then there's also medication units. But there's a lot of innovation happening in this space now, and there have been some recent changes at the federal level to make this even more accessible. And then finally, corrections, which I'm going to talk about more in a little bit. But I think that's a really important setting where equity can be addressed in terms of making sure people have access to treatment within the correction system or the criminal legal system. And then I just want to address this image that I have over on the right. The middle is kind of where we want to live in terms of substance use disorder treatment. So looking at the best research evidence, I mentioned that medications for opioid use disorder are seen as the gold standard with the best outcomes for people with an opioid use disorder. But obviously a clinician and a doctor's, like, their perspective on what is best for their patient should also come into play. And the individual and the patient should get a say in how they're treated, and what treatment is best for them. So, a patient might, a doctor may say, oh, I think methadone is best for you. But a patient might say, I just don't have the ability to go to the methadone clinic every day at 5 a.m. And so finding those, the kind of the sweet spot between those three factors is ultimately going to be the best way forward. Okay, so diving a little deeper into treatment within corrections. This first part is maybe, one of the best ways to address equity in terms of diversion, deflection, and treatment courts approaching substance use disorder as a public health issue instead of a correctional issue. So looking at ways that people can be diverted from the criminal justice setting and treated in a medical setting instead. There are best practices for all three of these. Treatment courts in particular sometimes get a bad rap because judges are not doctors, lawyers are not doctors, but there are some best practices that have been created, and they involve the input and kind of a team-based approach with a medical provider. Within the criminal legal system, so like once someone is already involved in the criminal justice system, there's kind of three places that, like, three phases of care that can be examined and improved. The first is universal screening, making sure that everyone who comes in is screened for mental health, behavioral health, and substance use disorder conditions. I think a lot of times this doesn't happen because people worry, or the administrators worry that someone's going to screen positive for an opioid use disorder, and then they're not going to be able to give them treatment. So these things are all hand in hand, but this is kind of an ideal situation, is that everyone who comes in is universally screened for a substance use disorder, and then they're offered evidence-based treatment. So sound like a broken record, but for me, evidence-based treatment is the, that three-prong approach, but making sure that all three forms of medication are offered within a correctional setting. This has been a huge push over the past 5-ish years. I think there has been a lot of progress in a lot of places, but there are some barriers that are hard to ignore. Getting methadone into a correctional system means that facility either needs to become an opioid treatment program or needs to partner with an opioid treatment program. But there are a lot of examples out there of facilities that have done this successfully and have been able to offer all three forms of medication, as well as obviously those counseling and support services as well. And then finally, looking at reentry services, we know that people exiting the criminal justice system or exiting incarceration are significantly more likely to overdose, given a lower tolerance, a changing drug supply that they are naive to. So focusing on reentry services and making sure that when people come out of corrections or a correctional facility, that they have medical coverage, that they have a warm handoff or a connection to care, and that they have support in social and structural determinants of health, like housing and employment and all those things. So reentry is a big thing, but it can make a really big difference. And then finally, something I don't think we talk a lot about, but I think we need to talk about more, is community supervision. So looking at probation and parole. making sure that those systems are structured in a way that people are still able to access the treatment they need. And also addressing stigma within all of these areas. I've seen some really interesting programs where correctional officers are being trained in substance use disorder and in medications for opioid use disorder. There are, right now, it's anecdotes, and I know that anecdotes are not data, but there are some studies being done about medications for opioid use disorder being offered within facilities and that bringing down infractions and improving people's behavior and just overall kind of positive impacts on a correctional facility. But I don't think we talk enough about community supervision, probation, and parole, and the ways that those systems could better serve people with substance use disorder. All right, moving along, recovery. This is the fourth bucket. This is from SAMHSA, the 4 pillars of lasting recovery: home, health, purpose, and community. I think there's a lot of different ways that these could be interpreted. And I'll also say there's a lot of really interesting stuff going on in this space right now. I'm part of a group that is working to look at the evidence that's out there in terms of what is most effective in promoting recovery and long-lasting recovery. So anyway, there's a lot of exciting stuff going on out there, but wanted to give everyone some things to think about in terms of barriers to successful recovery and facilitators to successful recovery. And I'm realizing at this point that I've kind of lost the equity theme, except that you think about all of these different spaces and there is inequity in every one of them, right? In employment, in housing. So if we can approach each of these barriers and facilitators from an equity lens, thinking about who is most in need of services, who is, most impacted, et cetera. Identification, I think this is one that we don't talk enough about. Again, you need an ID for so many things. Criminal history, like the criminal justice issues we already talked about, but having a criminal history can affect your eligibility for services, employment, your ability to vote and participate in a civic manner, your access to education and training. So thinking about certain licensures where a criminal record could impact your ability to access that licensure or that profession, and then housing. And I will say that for most of these, if it's a barrier, it could also be a facilitator if it was offered. So it's kind of which way do you approach it? So lack of access to services, if someone doesn't have food, their recovery is going to be a lot harder. You could also turn that into a facilitator, right? If someone has food or is connected to a resource, whether that's a food bank or food stamps, that could be a facilitator. Also want to include accessibility and disability considerations. There is a huge overlap in people with substance use disorder and people with a disability, whether that's caused by their substance use disorder or not. And I also want to acknowledge, it should probably be in the facilitator side, that there are protections given to people with substance use disorder through the ADA or the Americans with Disability Act. So just want to put that in the facilitators common column that those could be services or places where people could look for support. All right, I'm going to keep moving because I'm realizing I've been talking for a long time. I want to acknowledge here, and I've mentioned it several times, but stigma is really the overarching thing that impacts all of these different areas, right? Someone's ability to access treatment and the treatment that's right for them, ability to access harm reduction services. Obviously, it plays a role in recovery and prevention as well. So I've mentioned that at Shatterproof, we do quite a bit of stigma work, partnering with states. I'm going to skip this. It's going to be sent out to you, but this is just talking about some numbers behind the impact of stigma in people with substance use disorders' lives. And then finally, we define 4 different kinds of stigma. So public stigma, structural stigma, self-stigma, the stigma that a person with a substance use disorder feels, and then specific stigma against medications for opioid use disorder. And then finally, I mentioned I'd leave you all with some resources. This is the Johns Hopkins site for the principles. They have a link up at the top, implementation tools. They might have changed it. I'm not sure if they've changed it yet. They were going to change it to say resources. This is kind of the acknowledged compendium of all the different resources out there for everything around opioid settlements and interventions that are the kind of best practices and evidence-based programs or policies. And then finally, this is not totally comprehensive, but these are a number of the organizations that are working in this space that have resources. Some of them provide technical assistance or tracking, or there's just a lot of different stuff going on in this space, and I'm happy to talk more about any of that. My email's at the bottom. I'm happy to answer any questions or provide guidance or connections or anything else that is helpful. And thank you again for having me. And I think we have some questions. I'm seeing the numbers in the chat, but I haven't looked.
Kristen, thank you very much. Before we open up for asking questions, please feel free to include them in the chat. I'm going to put in some information about a workshop that is coming, in-person workshop that is coming up. Adam, do you want to talk about the October 19th session in Charlottesville?
Yeah, thanks, Jennifer. That's yeah, definitely take this opportunity to plug this in-person workshop. So we're doing 4 of these. We've already held one in Abingdon, and that was really a huge success. So we've got another one coming up in Charlottesville on October 19th. So we've got a pretty fantastic group of speakers and service provider attendees lined up. So I encourage you all to attend if you can. You can register for this event on our website at oaa.virginia.gov. Click on the Abatement Academy tab, and you can look at the agenda and register for that event if you so choose. But again, it really great opportunity. If you can make it, we would encourage you to do so.
Great. So we have 4 more Opioid Abatement Academy sessions left, the 2nd and 4th Thursdays of each month. So be sure to join us in for this. Kristen, we've just had one question come in. And even though a number of people in the good community that we have here have also responded to it, I'd like to get your take on this. Do you make allowances for people who don't want to use methadone or bupropion? Would you prefer a 12-step alternative?
Yeah, that's a totally fair question. We talk about medications as if there's no other options, and of course there are. And that's why I think that image with the 3 different aspects is so important, because a person's preference or choice is so important. Not everyone wants to be on a medication, and that is totally viable. I think the reason we talk so much about medications is because that's where so many of the structural barriers are. I think that there's so many structural barriers to accessing buprenorphine or especially accessing methadone, that we talk about removing those barriers a whole lot more. But there are a number of abstinence-based programs out there. Some people start on medication and then decide that they don't want to continue. They work with their clinician to taper off and then use abstinence-based support services. There is no one size fits all. I think it's really important, though, that everyone has access to all the available options so that they can choose what's right for them with their clinician or provider.
That's a great point. Okay, well, that was the only question that came into the chat. Kristen, thank you so much for. Oh, here we go. Are there any continuum of care models for how hospital systems are handling complex medical and OUD cases from a policy and equity standpoint?
I don't know if I've seen any models. I love a good model, so I'm going to go look for one. I don't know that I've seen any like clear models. I know we have a lot of great examples, especially in like emergency departments. A lot of places, like I know that some hospital associations have created protocols for how overdoses should be addressed in an emergency department. Stuff like, access or initiation of medication, warm handoffs. There's a whole bridge program out in California that I know some places have used that model to emulate in their communities. So there's a lot of different, I guess it's a model. I'm thinking of like a visual model. There are a lot of great examples out there of ways that hospital systems are doing this. I know of some hospital systems that, someone comes through an emergency department, through an overdose, and they have a treatment facility on site at that hospital. So the person doesn't have to go find another provider. It's a very warm handoff to the treatment facility that's downstairs or, you know, just in the next wing or something like that. So there's a lot of good examples out there, but I can't think of any like visual model. I'm not sure which the person is referring to, but yeah.
Great. Well, those are all the questions that we have today. Kristen, thank you very much for your time. And I hope people stay tuned. All those who are registered, I will send out the PDF of Kristen's presentation today, as well as any resources that she wants to share with us. Again, thank you again, Kristen. Thank you everyone for joining us.
Thank you for having me, and don't hesitate to reach out if anyone wants to follow up. Thanks again.
Thank you.
Thank you all.